Hi everyone, this is Tim, your Block 3 lecturer instructor, and this PowerPoint voiceover is on gastrointestinal, primarily the upper GI. So we're going to cover the GERD, hiatal hernia, and peptic ulcer. So for the GI tract, we're going to cover mostly the esophagus to the stomach. This is including the esophagus, the esophageal junction, and the stomach. So for the first disease process, we have GERD, which is gastroesophageal reflux disease. It is the backflow of gastric or duodenal contents into the esophagus. This is caused by an incompetent lower esophageal sphincter, pyloric stenosis, or motility disorder. So essentially, this is coming down to a patient eats either too many acidic foods, or the actual stomach itself is not able to break down and causes more acid to be produced. But the actual sphincter itself is not closing either correctly, or it's not completely closing, and this is causing the gastro contents to actually kind of build up. I call it vapors. So basically, you eat some really spicy food and your body's producing a lot of acid in order to actually break it down, and that sphincter doesn't completely close all the way, and like I said, those vapors are kind of rising up, and that's what's causing the actual symptoms of the actual GERD itself. Now, as far as assessment-wise, this is where you're going to get heartburn, epigastric pain, dyspepsia, regurgitation, difficulty or painful swallowing, and hypersalivation. I will tell you that me personally, me having GERD, the heartburn is usually the first symptom that I have, and the regurgitation is probably more. I know once I get the heartburn, that the regurgitation is going to probably come after that. Now, this is not necessarily actual vomiting, but it's just more of that. You can get a little bit of burning in your throat. You can get a little bit of kind of like a bad taste. You do get that hypersalivation because you're trying to, the more you salivate, the more you're able to swallow, the more you're trying to push those vapors and that stuff back down into your actual stomach. The epigastric pain is probably more of it's there, but it's not necessarily painful per se. It's probably more of an aggravation than anything else. Now, as far as interventions, avoid foods that cause esophageal irritation. Peppermint, chocolate, coffee, alcohol, fried fatty foods, and cigarette smoking. So I can tell you that peppermint and chocolate and the coffee, those three things, those actually have ingredients in them that actually don't allow or cause the sphincter to dilate. So by avoiding those things, you're actually solving the problem of the sphincter being dilated or not closing correctly. As far as fried fatty foods, this is really just causing more aggravation into your stomach, and your stomach having to produce more gastric content in order to actually break it down. So if your patient stops eating the fried fatty foods, the acidity and the amount of stomach acids being produced will actually cut down, which will actually cut down on the symptoms of the GERD. As far as cigarette smoking, it's the same thing. It actually will cause some irritation on that sphincter and cause it not to completely close. Eat low-fat, high-fiber foods. Avoid eating or drinking 2 hours before bed. Elevate the head of the bed 6 to 8 inches. Avoid NSAIDs and take antacids, H2 receptor antagonists, proton pump inhibitors, and possibly surgery. So, for those patients who have GERD, there are simple interventions and things that they actually could do to cause the actual symptoms or the problems that they will have with it. So if they avoid eating and drinking before they actually go to bed, at least 2 hours, by then the stomach actually starts to empty and starts to break all that stuff down. So by the time they're ready to go to bed, it's not really there. The worst thing they actually can do is eat, go to bed, and then lay flat, because at that point all the stomach content is more even with the esophagus, and that's what causes the regurgitation. Elevating the bed 6 to 8 inches, again, it puts you at a slope that allows your head to be raised, so gravity keeps all that stuff more in their stomach than anything else. So avoid NSAIDs, which is more of an irritant on your stomach. Taking antacids and H2 receptor antagonists and proton pump inhibitors, this will actually decrease the amount of acid that's in your stomach. A lot of times what will happen is that patients will produce an overabundance of acid, and that will cause the regurgitation, not necessarily what they eat or drink. So by taking some sort of medication, this will actually reduce those symptoms. So for the most part, it's either your patients are having the symptoms based on what they actually eat, and if they learn what not to eat or learn what causes the problems and reduce them, the problem will go away, or they're actually producing too much acid, which is an anatomical problem, and again, the taking medication will actually help with that. Surgery, I've actually had some patients that have had anatomical dysfunction with the sphincter itself, which is at the base of the esophagus, leading into the stomach, and they've actually had surgery where they allow the sphincter to actually close altogether. So, for antacids work by counteracting or neutralizing the acid in your stomach. They do this because the chemicals in acids are bases. So basically, if you're taking Tums or Malax or something that's actually a base, it will actually neutralize the acid in your stomach. For magnesium, this contains acids. They tend to be more of a laxative. So when you take milk of magnesia, yes, it's a great medication to help neutralize the acid in your stomach, but one of the side effects is it's actually causes diarrhea because it is actually a laxative-based medication. Histamine H2 antagonists. H2 blockers are a group of medications that reduce the amount of acid produced by the cells in the lining of the stomach, and the most common is famotidine and retinidine. So these two medications themselves actually reduce the amount of acid produced in the stomach itself. Proton pump inhibitors, or PPIs. These actually reduce the production of acid by blocking the enzyme in the wall of the stomach that produces acid. So the one actually reduces the acid in the stomach, and then the other one actually reduces the production of acid. They're also longer lasting. Proton pump inhibitors, the most common are omeprazole, which is Prilosec, Nexium, Prevacid, and Protonix. Those tend to work better and be more prescribed in the hospitals because they do actually last longer. The next disease process is the hiatal hernia. A portion of the stomach herniates through the diaphragm and into the thorax. Aggravating factors, which kind of stands to reason, is pregnancy, because obviously it's pushing up on the actual stomach and the diaphragm at the same time. Ascites will do this, obesity, tumors, and heavy lifting. Complications are including ulcerations, hemorrhaging, and regurgitation of stomach content. The stomach content is so acidic that, for those who have GERD, it actually starts to burn and starts to cause erosion of the esophagus itself, which leads to the ascites, and it can also lead to esophageal cancers and stuff. So between the GERD and the hiatal hernia, a lot of these, it sounds pretty common in today's times as far as, if we throw pills at people and just tell them to take it and the problem will go away, they'll feel better, which they do. But in the same sense too, a lot of times, if we're not really careful and taking care of the problem and changing the way people eat and how they live their life, or lifestyle changes, this really could lead to serious problems down the road. Here's a picture of the hiatal hernia. Assessment-wise, you actually have heartburn, regurgitation, or vomit. You'll have dysphagia and feeling of fullness. So again, it's not far from the actual symptoms that you usually get with GERD. Interventions, you're going to take antacids, you can take H2 antagonists, you can take proton pump inhibitors. Surgery will actually fix the hiatal hernia problem. You want to do small, frequent meals. You also want to do this same thing with GERD. The more you can eat small, frequent meals, the more your body will know what to do. And so think about it this way. You sit down, you eat a really huge meal, and it takes all your energy to be able to produce enough acid to actually break that down, and that may take a while for it to actually digest and to actually be processed and pushed through to the intestines. If you do small, frequent meals, your body doesn't have to work as hard, it doesn't have to produce as much acid, and it actually is much quicker for it to be processed, digested, and actually pushed into the intestines themselves. So the small, frequent meals is really good for a lot of disease processes, specifically GERD and the hiatal hernia, because of the fact that it'll lessen and be better for those disease processes. limit the amount of liquids taken with meals. And the reason why this is because we tend to eat and drink at the same time, and this actually makes you fuller, and it actually has more liquid in your stomach, and then your more acid has to be produced to be able to break both down. Do not recline for at least 1 hour after eating. Again, this is more of a gravitational problem. If you eat and sit up and let your food actually digest, that it keeps things where they're supposed to be. If you eat and we tend to eat and sit in the recliner and watch TV, and because of that, we're really kind of more of an angle and not really keeping things where they're supposed to. Avoid anticholinergics, which delay stomach emptying. And anticholinergics are actually a muscle relaxant and a paralytic, so it actually doesn't allow things to kind of move and process the way they're supposed to. So when all else fails, or with a lot of other disease processes, you possibly could get a peptic ulcer. The stomach normally produces acid to help with digestion of food and kill germs. The acid is corrosive, so your body produces a natural mucosal barrier which protects the lining of the stomach from being worn away or eroded. So with GERD or any other disease process that produces a lot of acid in the stomach, if you're not neutralizing it or getting rid of it, or you're producing way too much, it actually will start to actually erode the lining of the stomach. And because of that, it will really eat a hole in it, and that's where you actually get the ulcer. In some people, this barrier may have broken down, allowing the acid to damage the stomach and causing the ulcer itself. So most common are gastric and duodenal. So the ulcers are produced by or caused by too much acid being produced. And again, it's so acidic and it's so painful and burning that it actually will cause holes to be produced. Here's a picture of the peptic ulcer. Let's see here, formation of painful sores or ulcers in the lining of the stomach or first part of the small intestines rarely occur in the lower part of the esophagus. The reason why that is because the gastric content itself, it doesn't fill the entire stomach full. It actually will probably fill at least halfway or 3/4 of the way. So that's why the ulcers are usually more in the lower portion of the stomach. Causes could be stress. The more stress you have, the more acid is produced. Smoking, same thing. Corticosteroids, NSAIDs, alcohol, family history, and infections such as H. pylori. Assessment-wise, for the gastric ulcer, you're going to have the gnawing, sharp pain in or left of the mid-epigastric region. It occurs 30 to 60 minutes after the meal. Hematemesis is more common than melena. So basically what happens is that you will have the pain in the mid-epigastric region 30 to 60 minutes after the meal, because at this point your body's producing more acid to break down that food. So the acid is what causes the ulcer to be irritated. With duodenal burning pain in the mid-epigastric area occurs 1.5 to 3 hours after the meal and during the night. This is caused because of where it is. The food is digested, acid is produced, it breaks all that stuff down, and it pushes it into the small intestines, and that's where it actually starts to aggravate that ulcer. Melena is more common, and pain is often relieved by indigested food. So as far as vital signs, you're going to monitor vitals for signs of bleeding. So we've mentioned in other PowerPoint voiceovers that blood pressure goes down, heart rate goes up. That's a symptom of either dehydration or some sort of lack of fluid. So if you have a patient who comes in with a GI bleed or a suspected GI bleed, and we're doing vitals and their blood pressure is low and their pulse rate is high, most likely it's a circulatory problem. They've bled enough internally from the ulcer itself that they've lost it, and the circulation wise it's actually too low. You're going to put them, first of all, you're probably going to put them as NPO until they actually do some sort of scope to find out if that truly is the problem. Have them have nothing to eat or drink, because obviously they don't want to look at that food while they're looking for other problems. But if they determine that it is a GI bleed, that will resolve on its own. The interventions are going to be a small, frequent, bland meals. The small, frequent meals is going to allow less acid to be produced, so that way it digests a little bit easier. The bland meals is because the more spicy things are, the more acid is produced to break that down. They're going to administer an H2 receptor antagonist or a PPI, administer antacids or neutralizing gas secretions. So at this point, you do still need to have a stomach that produces acid for just the sake of the function of the stomach and what it's supposed to do, but in the same sense too, you don't want it producing an overabundance of acid because you want that ulcer to heal. There could administer mucosal barrier, such as saccharifate. I want you to know this medication. This medication is specifically meant in targeting peptic ulcers. A patient will take it breakfast, lunch, and dinner. Basically, they'll swallow it. It goes down to the stomach. It gets broken down, and it acts as a band-aid for that ulcer itself. So it goes straight to the ulcer, puts a protective coating over it, and allows the acid to be produced without causing more irritation to the ulcer. Another thing you actually can also administer is prostaglandins, and we'll talk about that in class. So for patient education, they're going to avoid consuming, spicy foods, do the small frequent meals, avoid the peppermint and the alcohol. I mean, all the things that they know that are going to cause more acid to be produced. And a lot of times it is really a trial and error. You can eat something, go, oh, I shouldn't have eaten that. And then you try to eat it again. You're like, yeah, I definitely shouldn't eat that. So a lot of it is, small frequent meals, bland foods, things that are easily able to be digested. And like I said, a lot of it is trial and error of what works and what doesn't. Definitely avoid smoking, avoid NSAIDs because that will actually cause more damage to the lining of the stomach and will cause the ulcers themselves. And then sleep well and avoid stress. Avoiding stress will cause less acid to be produced, and then sleeping well allows your body to actually heal. As far as the GI bleed, so gastrointestinal bleeding, also known as gastrointestinal hemorrhaging, is all forms of bleeding in the GI tract from the mouth to the rectum. When there is significant blood loss over a short time, symptoms include vomiting red blood, vomiting black bloody stools, or actually having black stool altogether. So a GI bleed is bleeding from anywhere from the esophagus to the rectum itself, and it could be for a million different reasons, and we'll cover some of those. Interventions during inactive bleed. So monitor vital signs for the bleeding itself. Remember, low blood pressure, high heart rate. Make sure that they're actually NPO because they're going to definitely either do some sort of EGD to look from the mouth to the stomach to the small intestines to see if there's a reason why they're bleeding, or they may end up doing a colonoscopy to go the other direction from the rectum up to the small intestines to find out if there's a reason why they're bleeding there. Definitely do IV fluids because you want to keep them hydrated and also replenish what they're lost from bleeding. You're going to do eyes and nose. Again, what goes in must come out. You're definitely going to do an H&H or a hematocrit hemoglobin to find out how much they have bled or if they're currently bleeding. And you may end up having to do a blood transfusion based on how low their H&H are. Here is a picture of the EGD. So again, they're basically going to take a scope. They're going to go through the mouth, down the throat into the stomach, and look from there into the small intestines and see if there's some sort of ulcer. It doesn't take very long. We will probably cover more in class as far as what this entails. Make sure the patient is NPO, making sure that they're alert and oriented, making sure the doctor has explained the procedure to them, make sure that they understand the procedure, make sure they can sign the consent form, just little things like that. All right, so that's pretty much it. Very quick and easy. Like I said, we'll cover most of this in class as far as specifics, but like I said, this was really just to give you an idea of what the upper GI as far as disease processes there are.